Assalamualaikum warahmatullahi wabarakatuh. Selamat sejahtera and a very good evening to everyone. Welcome to the oral presentation for Room 1 Medical and Health Sciences for Clinical Research category. My name is Tengku Muhammad Asri bin Tengku Mahtar and I am your chairperson in charge for this room. For the program, before the program begins, we will recite the Ummul Kitab Al-Fatihah. We hope today program goes smoothly. Al-Fatihah. Bismillahirrahmanirrahim. Amin, 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 ya Rabbal Alamin. Ladies and gentlemen, firstly, I would like to introduce to all the presenters our judge for today. The first judge is Associate Professor Dr. Hermizi Hafidin from University Science Malaysia. Welcome, Doctor. And the second one is Dr. Yusmazura Zakaria, also from University Science Malaysia. Before we start our session, I would like to remind all of the presenters regarding our program today. Please mute your microphone and turn off your camera. You can only switch it on during your Q&A session. The slides will be handled by the technician. Once the slide video has ended, please turn on your microphone and camera for the Q&A session. Once your Q&A session has ended, please turn off your microphone and camera. Please take note that the duration of your presentation is 10 minutes and your Q&A session is 5 minutes only. So, without further ado, we shall begin now with the first presenter. I would like to call upon the first presenter with the code M02, Muhammad Rafiq bin Essan from University Science Malaysia, to present his research entitled A Study of the Association Between Labor Epidural Analgesia and Chronic Low Back Pain, a Malaysian Retrospective Study. Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum and hello everyone. I'm presenting my dissertation topic entitled Does Epidural During Labor Lead to Chronic Low Back Pain? It's a retrospective cohort study. This is my team, consists of me, Dr. Muhammad Rafiq Essan, my dissertation supervisor, Dr. Wan Fazlina, and my academic supervisor, Professor Dr. Samso. As an introduction, labor pain remains the common intense experience by patients during interpartum period, and epidural analgesia is deemed as the best treatment for pain relief during labor. Interestingly, there have been a recent widespread publicity in the social media focusing on perception that epidural analgesia during labor can lead to the new onset of chronic back pain. However, this association remains controversial and has not been tested locally. Our review of current literature indicates that all the studies on the relationship between labor epidural analgesia and chronic back pain was conducted mostly in the Western population and one study in Pakistan. Factors such as a smaller body weight, body mass index among Malaysians as compared to the Caucasian may lead to different results being obtained in our population. So we consider it is desirable to establish our own finding whether labor epidural analgesia is indeed free from the long-term morbidity, especially chronic low back. So our objective is to compare the incidence of new onset low back pain at the 6-month period after delivery. Secondly, we want to assess the severity of back pain and its related disability. And thirdly, we want to examine if labor epidural analgesia is independently associated with the chronic back pain, comparing from the epidural group and non-epidural group. So our study design is a retrospective cohort study in the Labor Room Hospital, University Science Malaysia, from September 2019 to June 2020, and it was ethically approved. As an inclusion criteria, we include the primary women, delivered first baby via the normal vaginal delivery, and we will exclude the multiparous woman with history of chronic low back pain, having a spine deformity, and woman delivered by cesarean. After screening the eligible women based on inclusion and exclusion criteria, we contacted by telephone and we assessed the primary outcome, which is a back pain, and we assessed the secondary outcome related to severity of back pain and disability related to functional impairment. This our data collection regarding the demographic. We will assess or analyze the age, BMI, education level, employment status, and marital status. For the obstetric, we will assess the duration of labor and birth weight of the newborn, and we will assess the primary outcome, which is a back pain 6 months post-delivery, and the secondary outcome, which is a severity based on 10 points Likert scale, as well as the functional disability impairment by using a validated questionnaire from the Oswestry Disability Index. For the statistical analysis, we use the SPSS version 26. For the categorical variable, we compare with using chi-square test. For the numerical variable, we compare with independent t-test. And for adjustment potential confounder, we use multivariate logistic regression analysis. For the sample size calculation, to achieve 80% power with an alpha error of 5% to detect 2.54 increase risk of post-delivery back pain in women administered with epidural anesthesia, a sample size of 200 sample was needed. That low back pain occurred at the estimated 12% prevalence in non-epidural group, which is this 200 sample include the 20% of drop rate. This is the result. This is the table showing baseline demographic obstetric variable of women receiving the non-epidural anesthesia versus epidural anesthesia. Of 200 women who were analyzed, 100 of it was the epidural group and others was non-epidural group. This table summarizes the baseline demographic and obstetric characteristic of the respondents. Women in both groups were similar in terms of education level, age, marital status, and birth weight of their newborn. However, compared to those from the non-epidural group, the epidural group has significantly higher BMI with a p-value of 0.03, and the majority of the women in the epidural group were from the working class, which is p-value is 0.033, and women who had received epidural also had a significantly longer duration of labor than the non-epidural group with a p-value less than 0.001. This is the primary and secondary outcome of the woman receiving non-epidural versus epidural anesthesia. For the primary outcome of new onset of chronic low back pain, it was noted 37 out of 200 sample. 28 of 100 women in the epidural group developed new onset of back pain persisting 6 months post-delivery, compared to the 9% women in the non-epidural group with the p-value is 0.001. Among those who developed new onset chronic low back pain, the pain was moderate in severity with mean numeric rating scale pain score of 5.1 plus minus 1.1, while the associated functional impairment was minimal with the Oswestry Disability Index of 14.7 plus minus 6.7%. For the independent risk factor, subsequently to obtain the independent value of epidural anesthesia for chronic low back pain, we perform a binary logistic regression analysis with back pain as the dependent variable and baseline characteristic using the Enter method. After the adjustment for baseline imbalance, which is BMI, employment status, and duration of labor, the adjusted odd ratio of labor epidural anesthesia for development of new onset chronic low back pain was 8.1. No other variable remain as independent risk factor for development of new onset of back pain. So, as a discussion, in our attempt to find a relationship between labor epidural anesthesia and chronic low back pain, We found that the prevalence of new onset chronic low back pain at 6 months after delivery was significantly higher in women who were given epidural anesthesia during labor compared to non-epidural. However, no difference was detected between the epidural and non-epidural group with regards to back pain score or level of back pain related functional impairment. The back pain was moderate in severity and the functional impairment was minimal in both groups. After adjusting for the potential co-founder, we found that using epidural anesthesia during labor remained as an independent risk factor for the subsequent development of chronic low back pain after normal vaginal delivery. The finding from our study also support the previous study by others that administration labor epidural anesthesia was associated with development of subsequent chronic low back pain. However, this association was not proven in prospective cohort study and the RCT randomized controlled trial. The limitation of our study, the inconsistency in the obtained result in the previous work raised the possibility of retrospective study being flaws by recall bias since the women were not randomized and consequently were self-selected from one treatment over another. Therefore, our study being retrospective in nature could not confirm a causal relationship between labor epidural and chronic back pain. Furthermore, reporting of the back pain by the woman may reflect the emotional reaction towards receiving epidural anesthesia during labor, an unconfirmed causal relationship between of this retrospective in nature needs to be confirmed by randomized control trial. The strength of our study, it is the first to test whether epidural anesthesia for labor was associated with chronic back pain in Malaysian population, and this implies that randomized control trial is worth to be conducted in order to confirm or refute our current finding. In conclusion, we demonstrated that labor epidural anesthesia was associated with the development of new onset chronic low back pain, although the back pain was moderate in severity and minimally interfere with the daily function of the woman. However, given the retrospective nature of our study design, such as association doesn't confirm causation. Therefore, a further randomized control trial RCT is necessary to establish whether or not epidural anesthesia is actually correlated with chronic pain. This is the references. We want to acknowledge the labor room staff and also the record staff for facilitating the process of data collection as well as the financial support from the Geran Penyelidikan Perubatan. With that,
Thank you. So let's proceed with the Q&A session. Over the judge and participants, you may now turn on your microphone and camera. So maybe Associate Professor Dr. Hermizi Hapidin or Dr. Yusmazura Zakaria want to say something?
Hello everyone. Maybe I can start first.
Yes, sure, Prof.
Okay. Thank you, Dr. Rafiqi, for the good presentation. Okay. May I know, your sample is involve all races in Malaysia or not? Or the majority of them are from Malay?
okay, thank you, Prof. Actually, most of the sample from the 200 sample, most of it is a Malay because it's collected in HUSM in Kubang Kerian. That's why most of population in Kelantan itself is a Malay. So I can say it's about 80% of my sample is a Malay population. Thank you.
Okay. In your opinion, is there any difference between among all races in Malaysian regarding the coping mechanism or um, emotional reaction based on your reading?
Alright. this is a retrospective study, and I can say when we ask the question, because we have a validated questionnaire regarding the functional status, functional disability complex, questionnaire. So based on this study, most of the Malay have some emotional like some sample we say we heard from someone the epidural will cause a back pain, and some said it's a very severe back pain and so on. I think this is a recall bias. That's why in our result we suggest to do a randomized control trial to confirm whether this is actually as an association is really happen between the epidural and low back pain. Thank you.
Okay. My last question. Do you have any reason of choosing a nulliparous or primiparous instead of multiparous for your subject?
Yeah, that's thank you. This is actually the first reason why I choose the prime parus, because from the previous literature they found there is co-founder, because a patient or woman with the multigravida means multiparous, so the incidence of the back pain is higher than the primiparous. That's why we concluded that I think my supervisor also agree with me. We choose the primiparous sample only to occlude the confounding factor.
Okay, thank you, Dr. Rafiqi.
Thank you.
Maybe we can proceed to Dr. Yusmazura for next question.
Thank you, Prof.
Yeah,
Dr. Yusmazura.
okay, thank you. Assalamualaikum and good afternoon, Dr. I just have a quick question. First of all, may I know are all your subjects receive epidural for the first time?
Yeah, Dr. Yus.
Can you hear me?
Yeah. Your question is, does all the sample is the first timer to give the epidural? Is it?
Yes.
Yeah, of course, it's the first time because it's a primiparous. It's a first pregnancy, so it's the first time receiving the epidural.
And based on the doctors now that you provided just now, I can say that the labor duration of labor is actually higher in the epidural side compared to the epidural.
Yeah.
Do you think that because of this increased duration of labor, so that it
Sorry, doctor, can you raise your voice? I cannot hear clearly.
sorry, since in your data just now your results, the duration of labor is actually increased for the epidural patient, right, epidural subject.
Mm-hmm.
So do you think that because of the higher duration or the longer duration labor will cause actually the for the back pain?
That's actually the another scope of study we can explore because we found out the epidural group have a longer duration of labor compared to the non-epidural group. And previous literature also said the same thing. There is also the study regarding the duration of labor, and the epidural is one of the cofactor that cause the prolong of the labor.
So meaning that actually the patient with epidural is actually because they have the higher duration of labor, then we need to do or we need to give the injection for epidural. Is it that so?
I cannot get your question, doctor.
My question is that because of the uh, duration of labor,
Mm-hmm.
so that we need to give the epidural to the subject?
If the epidural. Actually, epidural is one of the analgesic instrument. I mean, analgesic is hello.
Yes, hello. Yeah, I can
Yeah.
hear.
Your question if I cannot get really your question.
Uh, Actually, the epidural administration
Mm-hmm.
when there is a high duration of labor or because of the from the subject.
So, can someone clarify the question?
Is that okay? What I mean is actually for the epidural administration, is it request by the subject or it given when the labor duration of labor is actually takes long time.
Oh, okay. The epidural actually is depends on indication. Some patient, like say patient having a preeclampsia or pregnancy-induced hypertension or some comorbidity, we prefer to use or prefer promote the maternal to have the epidural. Some of the sample also requested to the epidural because epidural itself reduce the contraction pain. So it depends.
Okay, so your subject is actually like random.
Sorry.
So the subject is actually the randomized subject, right?
We do a retrospective study.
Okay. Okay, thank you, Doctor.
Okay. Sorry.
Okay, thank you to Dr. Yusmazura Zakara and also Dr. Professor, as I said, Professor Dr. Hermizi, and thank you to Dr. Muhammad Rafiqi too. So we proceed to the second presenter with the code M10, Sharmin Sultana from University Kebangsaan Malaysia with the title of The Efficacy of Modified Piezo-Scission Procedure in Elevating Maxillary and Mandibular Anterior Crowding in a First Premolar Extraction Case, a Pilot Study. So please welcome.
Assalamualaikum, respected chairperson of the scientific committee. I'm Dr. Sharmin Sultana going to present a preliminary report titled The Efficacy of Modified Piezo-Scission Procedure in Elevating Maxillary and Mandibular Intercrowding in First Premolar Extraction Cases. Now I want to tell what is piezo-scission procedure. DeBart et al. In 2009 first introduced piezo-scission procedure by using piezoelectric ultrasonic tools. The procedure involves vertical buccal interradicular gingival incision and the use of the piezoelectric bone surgery blade number 1 to decorticate the alveolar bone and termed as piezo-scission procedure. Based on this procedure, we slightly modified the procedure. In this picture, I want to show you we perform the gingival incision of both maxilla and mandibular anterior region. The gingival incision length 4 to 5 mm instead of 5 to 7 mm, and we perform the depth of the alveolar bone corticotomy 3 mm. And how we know that the bone corticotomy depth is achieved 3 mm? Well, in this picture, the piezoelectric blade, we can see there is a millimeter marker itself, 3 millimeter, 6 millimeter, 9 millimeter. And when we cut the bone and the blade reach about 3 millimeter, we can assure that the bone depth is 3 millimeter. And also we activate these orthodontic appliances 4 to 5 weeks instead of 2 weeks. In picture B, we can see the hemostasis is achieved properly. This picture was taken just immediate after the piezo-scission procedure and activate the orthodontic appliance. In picture C, we can see the gingival incision area of both maxilla and mandibular anterior region is start healing properly. Piezoelectric tools for piezo-scission procedure. This is the surgical blade number 1 and this is the piezoatome machine with continuous saline irrigation. So why we orthodontists are looking for accelerate orthodontic tooth movement? Well, because orthodontic treatment takes long duration, about 18 to 30 months to complete the entire treatment, depends on the severity of malocclusion and appliance design. So how piezo-session corticotomy procedure accelerate orthodontic tooth movement? When we perform intentional surgery, either soft tissue or hard tissue, there is inducing regional acceleratory phenomenon. And how does it work? When we perform piezo-session procedure together with orthodontic force, it causes inflammation of that particular area, increase inflammatory markers of that particular area, and then increase osteoclast and osteoblast, thereby start bone remodeling and increase the tooth movement. So, what is the reason to conduct this study? Till now, only 9 randomized clinical trial studies published. Among them, 7 clinical trials found significantly shortened the orthodontic treatment time, and other 2 clinical trials found not significant result. Up to date, there is no study about the time required to reach the complete leveling and alignment stage of both maxilla and the mandible separately in first premolar extraction cases by performing this procedure. There is also insufficient evidence about the influence of piezo-session procedure on periodontal structure. The aim of this study was to investigate the efficacy of modified piezo-session procedure to accelerate orthodontic tooth movement in initial leveling and alignment stage of first premolar extraction cases of both maxillary and mandibular anterior teeth. Also to evaluate the piezo-session surgery effects on gingival recession and periodontal pocket depth. Research question: how long does it take to alleviating maxillary and mandibular anterior crowding in first premolar extraction cases by using this modified method of piezo-session procedure? Materials and methods study design, randomized clinical trial design based on consort guideline, reference population adult patient 18 to 30 years with 7 to 9 mm severe maxillary and mandibular incisor crowding according to Little's Irregularity Index, source population patient whom were referred to the Orthodontic Clinic, School of Dental Science, USM. Randomization, we performed simple randomization. Sample size calculation was performed using the statstudio.com online calculator, assuming that a minimum of 4 weeks to 28 days difference in treatment time between the two treatment groups. Using the standard deviation from the previous study conducted by Hassan et al., 15.29 days per set 0.9 and significance level set 0.05, the calculation showed that 6 patients per arm were recorded in this study. Considering a dropout rate of 30%, the study had recruited 8 patients, that means total 16 patients. However, in this presentation, I am showing total 6 patient preliminary report. During screening based on inclusion and exclusion criteria, we recruited patients and taken informed written consent from them, and we performed simple randomization to prevent the biasness of the treatment method, and we divided the sample size equal into 2 groups, control and experimental group. And we collect the data collection, we assess the gingival recession and pocket depth from first molar to first molar teeth, and gingival recession was measured. I am showing this picture from the cement to enamel junction to the free gingival margin, and pocket depth was measured from the free gingival margin to the alveolar bone crest, and we measured the pocket depth in 3 points. In this picture I am showing distobuccal, midbuccal and mesobuccal. The mean gingival recession and pocket depth changes was calculating by subtracting the score obtained from T0 and T3 time point. T0 time means before start treatment and T3 time means when you resolve the anterior crowding of both maxilla and mandibular teeth. So how we analysis of leveling and alignment treatment time? Well, we calculate the overall treatment time by the number of days between the T0 and T3 time point. T0 time means the day we start the treatment, and T3 time means the day we resolve the anterior crowding of both maxilla and mandibular teeth. And how we know that resolving the crowding? Well, we take this in the picture I am showing. We take the impression cast at different time point from both maxilla and the mandible, and we measure the incisor irregularity by using the digital slide calipers. We measure the irregularity by measure the horizontal distance from adjacent contact point of the 5 of the 6 anterior teeth, and this 5 measurement gave the value of the index. That's mean A plus B plus C plus D plus E is equal to little irregularity index value. And we take the impression cast at different time point. T0, that's mean before treatment. T1, that's mean first month of the treatment. T2, that's mean second month of the treatment, and T3, that's mean when you resolve the crowding or at the end of the leveling and alignment. This is the picture showing maxilla and mandibular cast at the different time point. And we perform orthodontic procedure. In both group receive the same MBT prescription bracket with 0.022 inch slot and buccal tube from first molar to first molar teeth. Experimental group receive additionally piezo-scission procedure along with this orthodontic procedure, and archer sequences maintain both group is same, such as 0.012, 0.016, 17 by 25, 19 by 25 nickel titanium archer. And when we resolve the intercrowding of both maxilla and mandibular teeth, we place the final archer 19 by 25 inch stainless steel archer. We follow up the visit every 4 to 5 weeks until crowding is resolved. Result: overall day to elevating maxillary and mandibular intercrowding was significantly shortened in the piezo-scission group than the control group in case of the maxilla. However, in the mandible, we didn't find any significant result. Pocket depth and gingival recession changes of maxillary and mandibular teeth, we find no significant changes in gingival recession and pocket depth, either both group or maxilla and mandible. Discussion: overall treatment time. In the maxilla, the current study found that the piezo-scission procedure significantly shortened the overall treatment time, mean difference 27 days, which is in line with the previous randomized clinical trial conducted by Essan et al. Also found significant result, mean difference 28 days. In the mandible, the present study found that the piezo-scission procedure did not shorten the overall treatment time, mean difference 24.67 days. The current study finding is not consistent with previous randomized clinical trial study conducted by Jibril et al. The author reported significantly shorter treatment time in the piezo-scission group compared to the control group, mean difference 77.9 days. The current study found no adverse effect on periodontal structure in either group of the maxilla and the mandible. These results are also in line with Charavet et al. Conclusion: piezo-scission seemed to be effective by reducing overall treatment time taken to correct maxillary anterior crowded teeth only, and convincing efficacy to the mandible without producing any adverse effects on surrounding tooth structure. Limitations: in spite of the value of a pilot study, it has its own limitations, particularly its small sample size, thus only be considered as preliminary report. Suggestion: to complete this randomized clinical trial to see the actual efficacy of the piezo-scission procedure. These are the references. Thank you for your patience.
Thank you to Shamina Sultana. And now let's proceed with the Q&A session over the judge.
Okay, Assalamualaikum. Okay, Dr. Sharmi, can you hear me?
Yes, I can hear you.
Okay, thank you for the good and informative presentation. Okay, based on your presentation, the the piezo-scission procedure.
Piezo-scission.
Yeah.
Yes.
Will cause the small gingiva recession. Am I right?
Are you asking about the adverse effect?
No, I just want to know the healing process when you do the incision to the gingiva. How many days?
How many days? Actually, I show you in the slides that only 1 week later it start healing, and after the 1 month it totally resolve. I mean, healing is very good. There is no problem, no scar mark reveal, nothing.
Did the incision will cause any pain to the patient?
Pain?
Due to the incision at the gingiva?
Obviously I use the local anesthesia of the particular area, So during the procedure, most of the patient did not feeling any pain. Actually, I also take the pain and satisfaction score, but I didn't present in this presentation. I leave it for further any conference or probably the publication. So I also measure the pain and satisfaction score. Mostly patient didn't take any paracetamol also after the procedure. We suggest that if a patient feel any pain, she can or he can take the paracetamol if necessary, but mostly patient didn't take it was very minor and tolerable pain, so they didn't take any painkiller also. So in my view, in terms of physician procedure, it doesn't cause any pain that much.
Because I always suffer ulcer at the gingiva, and it caused me a lot of pain.
Is if ulcer is different issue. In our gingiva, ulcer happen due to stress, due to in lacking of vitamin, some vitamin like riboflavin or vitamin C or vitamin B12. So in that case, sometimes, and also sometimes the trauma, like during eating, sometimes trauma happens. So if ulcer happen, then it will be painful if ulcer happen. But it is not a pathological condition. Ulcer is a pathological condition, but I'm doing intentional surgical. So during intentional surgical, there is a healing process start. There is lots of inflammatory marker arising on that particular area. So it start better healing, better bone remodeling. So ulcer is totally different thing. Ulcer is a pathological condition, but I'm doing it's totally physiological condition, under the physiological condition.
Okay, that's good if the procedure not cause any pain to the patient. Okay, my last question, can you explain to me why there is no significant difference between the two groups for the lower jaw mandible as compared to the upper jaw maxilla? Is there any
Actually,
scientific evidence?
Upper teeth, both upper and lower jaw, we took same crowding index, 7 to 9 millimeter. But I found in maxilla significant result in pediatrician group, but mandible there is no significant result. However, still in mandible is still the day, if we count the day, still it's less than the control group. That means it reduced, but that reduced time is not significant. Probably the reason is that based on the literature review search, we found that mandibular bone is more thicker than the maxillary bone. Maxillary bone thickness is less than the mandibular bone. So I think that is the another reason that I couldn't find significant result, probably, but still I cannot tell exact result, because some other author, Jibril et al., he found significant result in mandible. So this procedure is a very new method. So I think it's a need to more and more randomized clinical trial with large sample size, because I'm doing a small sample size. So I cannot give the concrete result, but I can tell in my study also I found reduced treatment time, but not significant.
Okay, thank you.
Thank you, Prof.
Thank you, Prof. So back to Dr. Yusmazura.
Hi, Dr. Shamin. Can you hear me?
Assalamualaikum, doctor. Yes, I can hear you.
Very interesting research, and you did a very well presentation. Actually, no questions from me. But, may I know, is it this procedure offered at our dental clinic?
Sorry, this procedure I perform in the dental clinic. Yes, in a hospital, University Science Malaysia orthodontic clinic. It's a specialized clinic. So I perform this procedure in orthodontic clinic.
But it's not offered for the patient yet, right? The procedure is not offered yet for the patient, right? It's still in
Yes, yes. We before we recruit patient, we tell everything procedure before we take the consent, informed consent. We tell the every procedure, everything. So what can be, what might adverse effect can be possible. So we tell everything, and then patient is willingly participate this research project.
Okay, thank you. Good.
Thank you to Dr. Yusmazura and also the Associate Professor, Dr. Hermizi, and thank you to Dr. Shamin Sultana. Okay, so we are proceed to the third presenter, but the third presenter have informed us that she has an emergency case and she could not attend this presentation. So we just proceed with her presentation only without the Q&A session. So from now, I would like to call upon the code of M16, Siti Nur Ashuda binti Madgani from University Science Malaysia to present her research entitled A Rare Case of Delta Beta Thalassemia in Malay Patient, a Case Report Study. Please welcome.
Assalamualaikum and a very good morning. I am Siti Nur Ashuhada binti Madgani, would like to present a case report entitled A Rare Case of Delta Beta Thalassemia in a Malay Patient. As an introduction, the beta-globin gene cluster locus is composed of 5 genes located in short region of chromosome 11. This locus contains epsilon, gamma G, gamma A, delta, and beta-globin gene. In adults, the beta-globin gene is predominant. Approximately 98% of all hemoglobin consists of HbA. Delta beta thalassemia comprise a heterogeneous group of disorders characterized by absent or reduced synthesis of HbA and elevated of HbF level. Delta beta thalassemia is caused by deletion of entire delta and beta gene sequence and only gamma globin gene highly expressed. Therefore, adults with this mutation have more than 1% of HbF level compared to normal adults. Beta thalassemia mutation are generally identified by significant elevation of HbF and HbA2 levels, while HbFH and delta beta thalassemia mutations are identified by elevation of HbF level but normal HbA2 level according to Galanello 2013. The 12.5 kb deletion in the beta-globin gene cluster is known as Thai-delta beta thalassemia, which commonly found in Southeast Asia. In Malaysia, most of the deletional mutation cases reported are from the alpha thalassemia. Published study involving the deletion in the beta-globin gene cluster are limited. However, in a report from Thailand, the prevalence of carrier for Thai delta beta thalassemia is as high as 4%. We would like to present a case study. A 35-year-old Malay pregnant lady was screened for thalassemia during antenatal hemoglobinopathy screening. She was found to have thalassemia as her FBC full blood count showed microcytic hypochromic and her HbF level was more than 1% by cation exchange HPLC. Subsequent electrophoresis, we did molecular screening to confirm the diagnosis. We use gap PCR in this molecular screening. Forward and reverse primer pair for Thai delta beta thalassemia were designed for interest region as described. PCR was performed in thermal cycle with this specific condition. Then the amplified product was analyzed on 1.2% agarose gel and visualized under UV light. As a result, we found this patient is Thai delta beta thalassemia carrier. As we can see in figure 1, sample P8, which is a normal control, did not show the targeted deletions. Meanwhile, sample P38, this studied patient, showed a deletion identified as 12.5 kb Thai delta beta thalassemia type using primers flanking in the deleted region, which produced an amplified product of 1,447 base pair fragment. For discussion, in Malaysia, most of the deletional mutation cases reported are from the alpha thalassemia. Deletions that affect the beta-globin gene cluster are uncommon. In Thailand, the prevalence of carrier for Thai delta beta thalassemia is as high as 4%. These findings can be explained by the proximity of the regions with Thailand and the frequent travelling of Malaysians and Thais to this area. The full blood count FBC with microcytic hypochromic in this study is in agreement with previously published data by Fucharon et al. 2002, which reported low mean values of MCV and MCH in HPFH6 and Thai delta beta thalassemia patients, together with high HbF but normal HbA2. Deletion at the beta-globin gene cluster that is associated with delta beta thalassemia trait leads to elevated level of HbF, while a moderate increment of HbF is associated with beta thalassemia trait. As a conclusion, Thai delta beta thalassemia has a very low incidence in Malaysia, and advanced molecular analysis should be performed to determine this rare mutation. That's all from me. This is my references and thank you.
Thank you to Siti Nur Ashuda binti Madghani. Because of an emergency factor, she cannot attend this presentation. So now we proceed to the next presenter. In the code of M18, Izmi Arifani bin Istal Zani from University Science Malaysia to present his research entitled Exploring Learning and Short-Term Memory Pattern of Arabic Numerals, a Functional MRI Study. So please welcome.
Hello, greetings everyone. Thank you for joining my session. I am candidate M18. My name is Izmi Arifani, and I will be presenting my proposal titled Exploring Learning and Short-Term Memory Pattern of Arabic Numerals, a Functional MRI Study. I am the principal investigator. My supervisors are Dr. Harizal as well as Dr. Aini. These are what I'll be covering today. So when thinking about the topic of memory and learning, when we look back, it is learned that memory is divided into three main facets, which are short-term memory, working memory, as well as long-term memory. And when we talk about learning itself, like right now when you are listening to my presentation, when we first start with the sensory input, and then the sensory memory will hold this information. We pay attention to it, and then this information will go into our short-term memory. Now, when there's maintenance and rehearsal of this information, it will then be processed and encoded into the long-term memory. And later on, let's say you want to use this information tomorrow, you will retrieve from your long-term memory. So when we talk about studies of memory, a lot of past researchers have used digits to study memory, and they have found that digits have many representational system in the brain regions. And other than that, they also have used Arabic numerals as a special character to represent this digit. Yeah, and other than that, other than Arabic numeral, also there are also studies that use symbols. However, researchers have found that Arabic numerals also needed a complex representational system, and it's been used to learn different memory patterns. Other than that, Arabic numerals are also used as like a new stimuli to see learning, so that it's not influenced by other knowledge. So it's a matter of like a new stimuli for to use for the research itself. Hence, this current study will also use Arabic numerals as the stimuli. Now, when we look into learning the functions and also the location of the brain regions in learning and memory, we will be using the fMRI neuroimaging technique to do so. So here are a bit of a comparison on other modalities as well, and I feel that fMRI will best able to help us achieve our objective. Now, when we talk about memory itself or even cognitive function, the brain development will help us know where is the peak age that the cognitive functions has been developed. So as we start from the antenatal stage all the way, as you go up all the way to 22 years old, for example, and they said that the peak cognitive performance is at the region of a mid-20s, and later on when you proceed further, then there will be cognitive decline. So other than that, past researchers also did share the importance of the prefrontal cortex development when it comes to memory formation. Hence, we will also hope to look into some of the activation in these regions as well. Now, here are some of the findings of past researchers that has done studies involving memory and Arabic numerals. So those in bold are the common findings among these researchers. They found that the prefrontal cortex, hippocampus, medial temporal lobe, posterior inferior temporal gyrus, and the marginal division of the striatum is being activated when they are doing these memory tasks with Arabic numerals. Other than that, there are also independent findings that some researchers actually saw there's an activation and some did not. Okay, and building on from this inconsistency, here comes the research goal itself. From the findings, it's still not well understood on the mechanisms of memory in human brain, and there are a lot of past studies also has used working memory and a combination of like short-term memory, long-term memory in their design. However, less of them actually target on the short-term memory, hence we want to build from here, and there are also a few that touch on learning new information. Hence, this study would like to build on past findings and explore the learning and short-term memory in different geographical contexts as we are doing in Malaysia. And we want to add knowledge into the current field of study. Now, here are my research questions. What are the brain activation associated with learning new information like Arabic numeral digits? What are the brain activation associated with short-term memory for Arabic numeral digits? And lastly, what is the difference in reaction time and accuracy of answer between single-digit Arabic numeral and double-digit Arabic numeral? Here are my general research objective. To identify brain area activation pattern associated with learning and short-term memory for Arabic numeral figures. Here are the specific objectives: to measure the brain activation of single and double-digit Arabic numeral during learning, which is the encoding phase of the task. To measure the brain activation of single and double-digit Arabic numerals during short-term memory, which is the memory phase of the task. Lastly, to compare the difference between the reaction time and accuracy of answers between single and double-digit Arabic numeral groups. Here are my hypotheses. Now, the hypothesis is based on the past findings as I shared earlier. Hence, we will expect that the prefrontal cortex as well as the marginal division of the striatum will be associated with short-term memory when performing the task in the memory phase. Yeah, and then there will also be an activation in inferior temporal gyrus, prefrontal cortex, when it's associated with learning during the encoding phase of the task. Lastly, the reaction time of answers for single-digit Arabic numeral will be lower, as compared to double-digit Arabic numeral, and the accuracy of answer will be higher in single-digit Arabic numeral group as compared to double-digit Arabic numeral group. Of course, null hypothesis will reject the statements above. Now, here are how am I going to do the study. So the study design is a non-interventional fMRI behavioral and task-related experimental design. The sample size will be 24 young adults and will be recruited via convenience sampling method, as I will have an advertisement of the study and I will share across social media platforms, text platforms, whichever that is convenient, and whoever that is also available and fit the inclusion exclusion criteria can join the study. And in terms of power size calculation, the sample size calculations, we use the 80% power alpha 0.05 according to Desmond and Glover, which they have done. Their study is actually about the sample size for fMRI, and they have recommended that at this setting that 12 participant is needed for one group. Hence we have two groups. We will double it up to 24 participants. Now here are my inclusion exclusion criteria. Basically, all subjects must be between 18 years old and 30 years old, healthy medical condition, and have logistic access to the study location, not pregnant. Exclusion will be if they are undergoing psychiatric illness, neurological illness, medication, have medical metal implants or claustrophobia, and have head injury history, cannot join. All subjects must not consume alcohol and caffeinated drinks 12 hours before the study, and all subjects must not have academic knowledge of Arabic numeral figures and word characters. Now all of these are self-reported. Now here are my data collection method. I'll be utilizing the 3.0 Tesla Archiva MRI scanner for the fMRI data acquisition, and this will be equipped with 32 or 16 or 8 channel sense head coil. My research paradigm will be a block design paradigm. There will be 10 single-digit Arabic numeral as a stimuli, as well as 10 double-digit Arabic numeral as a stimuli as well for the two groups. And I will have 6 blocks of task phase and 7 blocks of resting phase. Later on I will show a diagram of it, and the participants will need to go through 2 runs of this block paradigm. So this is the example of my task and the block design paradigm, the task as well as the resting block. Total will be 10 minutes and 2 seconds, including of 2-minute break between the runs already. This is the task paradigm. This is how the stimuli will be presented. Okay, so the stimuli will be presented in this way, and then later on they have to answer either A or B just to fit the Arabic numeral. Is it fit the answer or not? Okay, and I will be analyzing using the SPM12 embedded in MATLAB. And there will be pre-processing steps, as well as that we will be using the general linear model for fMRI analysis with a threshold of P.001, without correction P less than 0.5, and I will be also doing the comparison between the two means using independent sample t-test. Here are how the result will be presented. Just a dummy tables just to show how it looks like. And that is all for my presentation. This is just an example of how the study will flow, all right, and the timeline of the study. Thank you so much for listening. Here are my references, and I'll pass it back to the host for Q&A. Thank you.
Thank you, Mr. Izmi Arifani. So now let's proceed with the Q&A with the judge, Associate Professor Dr. Hermizi and also Dr. Yusmazura.
Okay, Assalamualaikum, Izmi.
Hi. You
Hi.
can see me, sorry.
Okay.
Okay.
Hi. So Izmi, you are presenting your proposal, not your research finding, right?
Yeah, it's just a proposal.
Okay. May I know your subject we consider both gender, male or female, or only one gender? Because you didn't mention in your presentation.
Okay, we didn't specify in there with the hope that hopefully we can actually get the same amount of gender, either male or female. But having said that, because we are actually looking at the brain structure itself, and in terms of which area is targeted when the memory is activated, hence we didn't really specify in terms of gender. So maybe gender differences could be a different form of the study. However, I would say we will include both lah.
Okay. Because I would like to know, is it any difference between gender regarding the memory and learning? It is a very good, interesting study to be done. Okay, my second question, do you have any reason for the inclusion criteria why the age range is
Set
between
as
18 to 30 years old?
Okay, so from the past literatures that I've collected, especially those that are doing this memory similar studies, I would say the participants they have recruited is also in those range because they did mention that that is where the peak cognitive performance is at. So if let's say the example, the participant is a bit too old, then they may perform at they already may have in the phase of cognitive decline. So we need to be careful with the age, and therefore a lot of the researchers also did mention that this is the range also that I shared before in terms of the brain development earlier in my literature review, that it is vital to ensure that these are they fall under this range to ensure that the brain is already developed. So we know that these are when we are gathering these data, we hope that when it's activated, they are also expected that, okay, the brain has been fully developed. So that is what we hope for.
My suggestion is it is better for you if you can put the reference in your inclusion criteria for the age range. Okay, so based on your presentation, there will be a number of methods to study the
I guess I need to play one more round.
memory and learning.
Come back.
Okay, sorry, what is the sound? Can you tell me why? What is the reason of you to choosing the fMRI instead of other methods?
Okay, so in a fMRI, the reason why we want to do it, first thing is that I'm interested to look at the function and also the structural activation as well. And from my readings, I believe that fMRI will be able to show the both signals, which is actually the functional side of the structure, and also MRI will give a I would say, quality of the image as well. Other than that, also it was I would say inspired by several other fMRI studies, and they did mention also that fMRI they have used fMRI for the current their study. So we would like to extend on that as well.
Okay, my last question. Based on your reading, is it possible to do the combination of method, for example, EEG and also the fMRI?
Oh,
Is it possible to be done?
I think definitely will be possible for a combination of neuroimaging techniques. In my opinion, I definitely think it's possible.
Okay, thank you, Izmi. Okay,
Thank you
now
so
I
much for the
pass to
question.
Dr. Mazura.
To use.
Yes, Assalamualaikum, Izmi. Actually, there's no questions from me. It's just, I think the suggestion from Dr. Armuzi, which is the combination method actually will be good for your studies. That's my opinion as well.
Okay, thank you so much.
Thank you, both judges and also Mr. Izmi for your presentations. And now we proceed to the fifth presentation with the code of N20 from Nurul Alia binti Abdurrahman from University Science Malaysia. And the title of the study is the preliminary evaluation for the inflammatory biomarkers interculin 1, 2-1 in chronic kidney disease patients with periodontitis. Please welcome.
Hello everyone, my name is Nuralia binti Abdurrahman master student from School of Dental Science. First of all, I wanted to greet to all respected judges of International Postgraduate E-Symposium 2021, my fellow participants and everyone here. It is an honor for me to be here presenting my study, the preliminary evaluation of the inflammatory markers interleukin-1 in chronic kidney disease patients with periodontitis. First, let's start with chronic kidney disease. CKD is a reduced kidney function shown by glomerular filtration rate of less than 60 ml per min per 1.73 meter square, or markers of kidney damage or both at least 3 months duration regardless of the underlying cause. We have 5 stages, started with the mildest one, stage 1, followed by stage 2 until stage 4, which is reversible. The end-stage renal disease, or known as stage 5, where is irreversible and only can be treated with dialysis and kidney transplant. CKD is a global worldwide, where global estimated its prevalence is 13.4%, meanwhile 60% for East Asia, and for Malaysia score with 15.48%, and this prevalence is still growing. The main causes of CKD is diabetes mellitus and hypertension, and we do have another risk factors of CKD such as age above 60, obesity, smoking, and family history. Periodontitis emerged as non-traditional risk factor of CKD now, yet limited studies have been reported on the current problem. So, what is periodontitis? Periodontitis is defined as an infectious disease resulting in inflammation within the supporting tissues of the teeth, progressive attachment, and bone loss, or also known as a gum disease. According to Unidu and Suite 2011, periodontitis is more prevalent in patients with chronic kidney disease and is also linked to inflammatory risk factors as well as other systemic and inflammatory conditions. So let's see how periodontitis can affect CKD. Periodontitis begins with accumulation of plaque where starch and sugar will react with bacteria in the mouth, and this will increase the GCF, gingival cervicular fluid, and this will favor the growth of bacteria. In order to fight the microbial infection, anti-inflammatory markers interleukin-1 were produced by immune cells. Interleukin-1 also promotes more mature immune cells to produce more interleukin-1b and TNF-alpha. Thus, later will promote T-cell activation, which is our adaptive immune response. Interleukin-1 will travel through circulatory system and increase systemic response to systemic inflammation. This induction of interleukin-1 in blood will increase chronic inflammation. Kidney failure can affect teeth, oral mucosa, periodontium, resulting in a negative effect on oral health. CKD patients with low immune response have dry mouth that enable to produce saliva to clean the mouth, so more bacteria are likely to form, thus lead to periodontitis. Basically, this slide shows how periodontitis have a bidirectional relationship with CKD. As for objective for our study is to determine and compare the levels of interleukin-1 in CKD patients with periodontitis at Hospital University Science Malaysia. This is a comparative prospective study, and we use convenient sampling method from March 2020 to March 2022, and all samples were collected at KPP Nephrology Clinic and KPP Periodontist Clinic USM. As for the participants, they were divided into 3 groups. Those 3 groups are group number 1, group chronic kidney disease with periodontitis, CKD-CP, second group periodontitis, and the third group healthy person. These all 3 groups, the age for all these 3 groups were 18 years old and above and must have 8 teeth. The inclusion criteria for group number 1 CKD-CP must experience CKD stage number 3 and 4, periodontitis and controlled diabetic. Meanwhile, for group 2, group CP must experience periodontitis, controlled diabetic but with no CKD. For healthy group, they must have any They're supposed to have any medical history, and they were excluded if they have take any antibiotics within last 2 weeks, pregnant or breastfeeding mother, take any immune suppressive drug and aspirin, or patient that have any history of rheumatoid that require them antibiotic. And this study was approved from Japan. As for material and method, for blood sample, 5 ml of venous blood were collected in gel-separated tube and centrifuged at 3500 rpm after 30 minutes, and all the samples were stored at -20 until further analysis. For interleukin 1 were analyzed by ELISA enzyme immunosorbent linked assay, and its data is analyzed via SPSS version 26.0. As our data are normally distributed, the descriptive were shown by mean SD, demographic data were also analyzed, and intergroup difference were evaluated using ANOVA. For interleukin 1 results between 3 groups, Group 1 showed the highest reading of mean SD with 0.35 compared to 0.22 for Group 2 and 0.11 for Group 3. Our result is statistically significant as the p-value is 0.001. As for discussion, it does show that CKD-CP groups have the highest level of interleukin 1 compared to other two groups. Silverstein et al. Study shown that CKD patients have higher serum of interleukin 1 levels than healthy people, which then raise the chronic inflammation. And Bastos et al. 2011 said that patients with CKD had more subgingival microbiota composition than healthy persons. This will result in increased inflammation and tissue destruction, as well as an increase in pro-inflammatory markers as a systemic response. According to Yajini et al. 2011, serum interleukin 1 levels was found to be higher in periodontitis patients' inflammatory gingival tissue. Our study showed that periodontitis is more severe in CKD patients than in healthy subjects. According to Arimutu et al. 2013, uremia in CKD will increase the gingival inflammation, which increases the chances of getting periodontitis. Therefore, more inflammatory markers will be released, resulting in an increase in systemic burden. Therefore, as a conclusion, our preliminary study concludes that CKD patients with periodontitis have an evidence of increased inflammatory burden, which may worsen the renal outcome. And for inflammatory marker, interleukin 1 is a promising inflammatory biomarker to assess CKD progression in this cohort of patients. As my suggestion, I would suggest that periodontal health of CKD patients need to be monitored and screened for early dental intervention. Before I end my presentation, I would like to thank to my main supervisor, Dr. Nurkayati Kasim, co-supervisor, Dr. Lailatul Akmar, Dr. Imran Kamaruddin, Dr. Farizan Ahmad, Professor Sirajuddin, and Associate Professor Dr. Wa Muhammad Amir, and not to forget Nanogene Solution, company that provide us the high quality of reagent, and this study was funded by FRGS. Lastly, this is all the references from my slide. Thank you everyone for listening to me.
Thank you to Ms. Nurul Alia. So now let's proceed with the Q&A, and Judge, your stage is closed.
Okay, thank you, Tengku Asri. Ya, Assalamualaikum, Alia.
Hello. Hello, Prof.
Hello. So Alia, your research is basically based on the FRGS grant.
Yes.
Okay. So based on your presentation, why didn't you show us the sample size calculation?
Oh, okay. I didn't show in the slide, but I can tell you the sample calculation was based on the previous study. We compared the mean from previous study, and we found that the minimum samples for our research is 15.
15 for
15
total.
15 for each group. For group number 1, group 2, and group 3.
Okay, so based on your result, your sample size is not reach the
Yes, since because of the COVID pandemic, so I cannot find the target lah.
Okay. May I know, is there any limitation from your research finding? Limitation from your research, and then based on your result, what is possible further study that can be done?
Okay, for the limitation, I can say that in each group we didn't have the same amount of races. We do have more Malay compared to Indians and Chinese. That's the first limitation. And the second one is before we did the dental examination to the subject, we're supposed to take the blood, the venous blood. But sometimes because of the issue, we have to take the blood after the scaling. So I hope there's no anything problem with the serum markers in the blood.
Okay. What is possible further study that can be done based on your current research finding?
Okay.
In your opinion?
Okay, in my opinion, I would say that we're supposed to have before and after treatment. So the biomarkers, the inflammatory markers should be compared before the treatment and after the treatment, which is 6 weeks after the treatment. So we can see either the inflammatory markers will be reduced or not. Inflammatory markers in each 3 groups will be reduced or not. That's all.
Okay, that's all from me. Okay, Dr. Yus, you can proceed.
Thank you, Prof.
Dr. Yus?
Ashwin.
Hello, doctor.
Hi, can you hear me? Hello?
Okay, I can hear you.
Okay, actually, so this quick question for me. So based on your findings, so, do you have any plan that you can advise for the management of patient with CKD and uveitis?
Can doctor repeat the question again? I'm sorry.
Do you have any specific plan to manage the person with CKD and uveitis in terms of treatment?
In terms of treatment, okay. In terms of treatment to CKD and periodontitis patient, is it, doctor?
Yes.
Okay. As I can say, maybe we can look further in the treatment as most of my samples of my subjects, they didn't come for the second review after 6 weeks. Mostly they come for the first review and then they stop for the second review, or sometimes they come after a few months for the second review. So that is how I can say to manage the patient in terms of the treatment.
Okay. Based on your method, your age of your subject is actually and above, right? So, above meaning that is there any limit?
18 until 17, or it will be nice if 18 until 69, because sometimes elderly wouldn't have enough teeth because we want 8 teeth, right? So mostly they have only 2 or use any they didn't have any teeth. So I would say 18 to 67 or 69, below than 70.
Okay, and on your study, average age that develop CTK and preventive, what the average age?
Okay. Most in my study, I realized that CKD patients always happen to subject to patient that age 30 to above. So we couldn't find CKD patient with 20 and below, because in this age, CKD only develop during stage 1 and stage 2. So we want stage 3 and stage 4. So stage 3 and stage 4 mostly common in stage 30 and above in CKD patients.
Because basically the CKD mostly develop in the older
Yes.
stage 3 and 4.
Because CKD getting worse when we getting older.
How about the pregnancy?
Sorry?
Is it related to age?
Sorry,
How
Doctor?
how about pregnancy? Is it related to age as well?
Okay, periodontitis also affect the adults, the older, the adolescents in a various form. So periodontitis also happen in stage 4 stages, which is gingivitis, slight periodontitis, moderate periodontitis, and severe periodontitis. So mostly patient with teenager patient will have gingivitis with a mildest periodontitis, which is they only have a inflammation in their mouth, which is can be treated with a brush their teeth. But stage 3, 4, and stage 2, 3, and 4 will be in older, elderly patient.
Okay, thank you, Alia.
Thank you. Thank you, Doctor.
Thank you to all judge and to Miss Nurul Alia. So now would like to call upon the next presenter with the code of M21, Harishini Rajaratnam from University Science Malaysia, to present her research entitled Detection of Anti-Neonatal NEF 1.5 Antibody in the Serum of 41 Orthotopic breast cancer Miss Model. Please welcome.
Greetings everyone, my name is Harishini Rajaratnam and I'm from University Science Malaysia. The title of my study is Detection of Anti-Neonatal NAV 1.5 Antibodies in the Serum of 41 Orthotopic Breast Cancer Mice Model. I'm truly honored to be part of this conference and I really hope that you'll enjoy my presentation. Breast cancer is one of the common types of cancer that occurs among women around the globe. Breast cancer metastases can be defined as the dissociation of breast cancer cells from the primary tumor to a secondary site which includes residual organs and lymph nodes. The expression of neonatal NAV 1.5 in breast cancer has been known to potentiate metastases. The 5' neonatal NAV 1.5 is the alternative splice variant of the LDAR isoform, which is NAV 1.5. The distinguishable 7 amino acid changes in the neonatal NAV 1.5 splice form is actually a unique feature that differentiates the neonatal and also the LDAR isoform. Over the years, the association between neonatal NAV 1.5 and breast cancer metastases has been studied using breast cancer cell line and also breast cancer tissues. However, a particular animal model has not been utilized in order to study the expression of anti-neonatal NAV 1.5. The immunogenicity of neonatal NAV 1.5 is reflected through the detection of anti-neonatal NAV 1.5 antibodies. In 2017, a breakthrough study by Yamachi et al. Highlighted the functional expression of neonatal NAV 1.5 in the absence of estrogen receptor. This particular statement resonates with the expression of neonatal NAV 1.5 in MDA-MB231 cells, which is a triple negative human breast cancer cell line. The 4T1 murine memory cell line has several features which makes it ideal in order to be incorporated into the present study. First of all, it is highly tumorigenic and invasive. Second plus point is that it is a triple negative breast cancer cell line which totally resonates with the fact mentioned earlier. The 4T1 cell line has been known to possess the expression of neonatal NAV 1.5 antigen, which makes it ideal in order to be incorporated in our animal model. The spontaneous metastatic characteristic of the 4T1 cell line contributes to our main goal. Till date, most studies have only focused on the molecular aspect of neonatal NAB 1.5, and the immunology side of this particular sodium channel has not been investigated yet. Therefore, in this study, we wish to look at the immunogenicity of neonatal NAB 1.5 by detecting the presence of anti-neonatal NAB 1.5 antibodies. We believe that this approach of using blood has a medium in order to detect the presence of anti-neonatal NAB 1.5 antibodies is a much less invasive approach as compared to using breast cancer tissues. In order to shed more light on the immunogenicity of neonatal NAB 1.5, our main objective of the present study is to detect the presence of anti-neonatal NAB 1.5 antibodies in the serum of 41 orthotopic mice model. To achieve the main objective, there are several specific objectives to be fulfilled, which includes to develop the 41 orthotopic mice model, followed by the validation of breast cancer metastases, and the detection of anti-neonatal NAB 1.5 antibodies in the serum of 41 mice and also control mice. And our last specific objective will focus on the expression of VEGF cytokine and its correlation with anti-neonatal NAB 1.5 antibodies. This is the ethical approval for the animal study. Now, let's have a look at the flowchart of the study. The first stage of the study was the cell culture of 41 murine mammary cell line, followed by tumor induction in biopsy mice. Once the tumor induction has been completed over the period of 42 days, the mice will be subjected to blood collection and also histopathology assessment. The collected blood samples will be subjected to ELISA analysis in order to detect the presence of anti-neonatal NAB 1.5 antibodies and also cytokine analysis for the VEGF expression. In this slide, we show you the correct method of securing the biopsy mice before the introduction of the orthotopic injection. The cultured 41 cells were introduced at the third mammary fat pad of the biopsy mice. Since we are investigating the presence of novel antibodies, therefore we could not find a particular commercial ELISA kit in order to do so. Therefore, we had to develop our own ELISA assay in order to detect the presence of anti-neonatal NAB 1.5 antibodies. A simple checkerboard titration method has been used in order to determine the optimum serum dilution and also secondary antibody dilution. This panel shows the development of 41 orthotopic tumor within a period of 42 days. Figure 8 shows the presence of 41 tumor in the orthotopic mice model, which was absent in the control mice. And an important feature of the 41 tumor is that it is highly vascularized. When the pattern of the tumor development was examined, it was noted that it showed a biphasic pattern and there was a decrease in the volume of 41 tumor in week 5. When the 41 tumor was examined via histology, there were several other features were noted as well, which include the presence of necrosis at the center of the 41 tumor, the presence of spindle-shaped tumor cells, and also the presence of leukocytes and blood vessels. Since the presence of neonatal NAB 1.5 is associated with breast cancer metastases, therefore it is important for us to validate the presence of metastases in the 41 orthotopic mice model in order to mimic stage 4 of human breast cancer. In our study, we found that there were prominent signs of metastases on the heart, kidney, liver, lungs, and also spleen. The sensitivity and specificity of the assay were both 100% and the ROC curve was used to determine the cutoff value for the detection of anti-neonatal NAB 1.5 antibody and has assumed all 17 orthotopic mice model exhibited the presence of anti-neonatal NAB 1.5 absorbance above the cutoff value, which was not seen in any of the control mice. As for the VEGF cytokine analysis, the 41 orthotopic group exhibited significantly higher expression of VEGF, and most important of all, the VEGF expression is positively correlated with the presence of anti-neonatal NAB 1.5 antibodies. Now, let's have a look at the discussion. The discussion has been shortened into several points. Let's begin with point number 1. So, how does the 41 tumor grow in the immunocompetent biopsy mice without being rejected? This is because the 41 cells share similar pattern of MHC class 1 as the parental biopsy mice. Now, let's shift our focus on the pattern of tumor development in the 41 tumor. So, based on the pattern, it was mentioned earlier that there was a decrease in week 5 in the tumor volume, which signifies the production of cytokines and antibodies against 41 antigens. The detection of anti-neonatal NAV1.5 antibodies signifies the immunogenicity of neonatal NAV1.5 in provoking the immune response. The presence of metastasis on the visual organs detected in the 41 autotopic model signifies the ability of the animal model in mimicking the advanced stage of human breast cancer. The presence of anti-neonatal NAV1.5 antibodies was only detected in the sebum of 41 autotopic model and not in the control mice. This corresponds well with the earlier findings proposed by Fraser et al. In the year 2005, where the presence of neonatal NAV1.5 is consistent with the presence of lymph node metastasis. The significant increase in the VEGF cytokine in the 41 autotopic model signifies sustained angiogenesis, which was apparent via histology and gross examination. The significant positive correlation between the expression of VEGF cytokine and anti-neonatal NAV1.5 antibodies may indicate the potential of these novel antibodies as biomarkers for the detection of metastasis. In conclusion, the detection of anti-neonatal NAV1.5 antibodies signifies the immunogenicity of neonatal NAV1.5. Since the presence of neonatal NAV1.5 corresponds with the presence of metastasis, which was validated via histology and also cytokine analysis, we believe that it could be used as a novel biomarker in order to detect the progression of breast cancer metastasis. These are my references and thank you very much.
Thank you so much to Ms. Harishini Rajaratinam. So now we proceed to the Q&A session, and here goes for the judge.
Okay, thank you, Mr. Chairperson. Hello, Hari.
Hello, Doctor.
Okay, thank you for the good presentation. Okay, I have only two questions. The first question is based on your second specific objective to validate the presence of breast cancer metastasized. Okay, is there any expert that help you in order to confirm the metastasis occur to the organs stated in your abstract? And my second question is, so your research is basically too fundamental. Can you briefly explain to me the impact of your finding to the society? Okay, with that, thank you, Hari.
Okay, sure, Doctor. Doctor, for the first question, in terms of confirming the metastasis on the visual organs, I have actually consulted with our pathologists who happen to be my co-supervisor as well. And plus, we actually associated with another veterinarian doctor. So we have physical examination and also pathologically. So we have confirmed both ways. And for the second question was on... Doctor, can you repeat the second question?
Impact of your study to the society.
Okay, so basically, Doctor, this is a preclinical study using in vivo modeling, and I have also performed a clinical research using breast cancer patients. So before moving into the breast cancer patients, I need to test first the immunogenicity of neonatal NAV1.5 so that I know it is present in the blood samples, and my impact to the community will be, so when we can test this particular marker by using blood samples, it is a much less invasive option instead of doing breast cancer biopsy, which is very painful and it is quite costly as well.
So when we have like this simple approach of using blood samples, it will create like it will eliminate the stigma around our community so that people won't be afraid to come forward and to do testing for breast cancer.
Okay, Dr. Yus, you can proceed with the question.
Hi, Ari. Good
Hi,
afternoon.
Doctor. Good afternoon.
My first question is it this neonatal NAV 1.5 only expressed specifically in the breast cancer?
Sorry, Doctor.
I think you mentioned that this neonatal NAV is actually potential for the biomarker for breast cancer. So is this neonate NAV 1.5 only specifically expressed in the breast cancer?
Yes, correct, Doctor. It is specifically expressed in breast cancer tissues only, and this has been confirmed by a previous study in the year 2017 by Yamachi et al., where they actually did like a screening, like an immunochemistry screening, using all the other tissues such as lungs, liver, and so on, and they found that we have neonatal NAV 1.5 immunoreactivity only in breast cancer tissues.
For both negative and positive, right?
Sorry, Doctor?
For both type of breast cancer?
Yes, Doctor.
Okay. And another thing is, may I know what's the method that you use to test for the antibody?
Okay, for the antibody, we created our own in-house ELISA assay. And how did we measure the antibody and the antigen specificity? It's basically that we have actually designed the peptide by manipulating the 7 amino acid difference between the neonatal NAV 1.5 and the LDAP isoform. So based on that specific binding, so once we have the process of washing the ELISA plate, so if there's no signal, meaning that there's no binding. If there's signal, meaning that there are presence of the anti-neonatal NAV 1.5 antibody.
Okay, that's good. And just one more question. Actually, for the metastasis stage, so all of the mice develop stage 4, right?
Yes, correct, Doctor.
Okay. So, in terms of when we want to apply the cancer patient, especially in order to become a biomarker for the treatment method because stage 4 already. So, do you think that this unit NAV so far there is any inhibitor for this NAV?
Okay. So far, Doctor, so when we implement the same concept of this experiment in using breast cancer patients, we actually had to design the experiment in such a way because the expression is actually manipulated by the presence of inhibitors such as breast cancer therapy. Inhibitors, the stages, and also the subtypes of the breast cancer will actually manipulate the presence of anti-neonatal NAV 1.5 antibodies.
Okay, thank you, Helen.
Okay, thank you, Doctor.
Thank you to Ms. Harishini and both judge. And now we proceed to the last candidate in the code of M39, Edina Muhammad Bakri from University Science Malaysia, with the title of the research is Adaptation and Validation of the Malay of the Nasal Obstruction Symptom Evaluation Scale NOSE. Please welcome.
Assalamualaikum and good morning to the all panelists. I'm Adina from USM. Today I'm going to present on my study, Adaptation and Validation of the Malay version of the Nasal Obstruction Symptom Evaluation Scale or NOS scale. Nasal obstruction is a common nasal symptom in either primary care, otorhinolaryngology, and also allergology clinic. It is defined as a discomfort or manifests as a feeling of insufficient airflow through the nose. It is a complex clinical problem involving either mucosa, structural, and even psychological factors. Causes of nasal obstruction can be various, but septum deformity is the main cause of this symptom. Other than history taking, there are several tools or objective measures have been used to investigate nasal obstruction. For example, like endoscopy nasal examination, rhinomanometry, acoustic rhinometry, as well as computer tomography or CT scan. However, subjective measures are also very important in assessing the symptom. Health quality of life questionnaires are among the most recent tools for assessing the changes of the symptom, the impact of the disease on the quality of life, and also the effectiveness of the treatment. The Nasal Obstruction Symptom Evaluation Scale is one of the health-related quality of life questionnaire, which was developed by Michael Stewart in 2004 in America. It is a brief and easy instrument to assess nasal obstruction. It composed of 5 items which evaluate the severity of complaints that the patient has been experiencing over the past 1 month. So while we performed the study, this scale has been translated into many languages all over the world and clinically validated to use. It has been adapted to European-based language such as French and Greek. Besides that, it's also already translated into the Arabic, China, Indonesian, and recently to Turkish language with a validity and reliability tested similar to the original version. Our main objectives is to validate the Malay adaptation and the nose as a screening tool for nasal obstruction. And for specific objectives, the first one is to translate original English version nose scale into Malay version, and followed by evaluation the validity and also reliability of the translated version. So now our questions is the Malay version of nose has good validity and reliability for assessing nasal obstruction symptom, and is it a good tool to assess patient with the nasal obstruction across the time? This was a cross-sectional study conducted in Otorhinolaryngology Head and Neck Surgery Clinic, Hospital Raja Perempuan Zainab II, and Hospital University Science Malaysia from May 2020 until March this year. Patients who came to the clinic with symptoms of nasal obstruction were enrolled into this study after they were consented. Our subjects criteria are aged 18 years old and above who understand Bahasa Malaysia. Patients who were having nasal obstruction at least 3 months and was diagnosed to have deviated nasal septum after the assessment. Patient also undergone septoplasty plus minor with the turbinate surgeries. Exclusion criteria are other nasal pathologies such as sinonasal malignancy, acute infectious sinus disease, and granulomatous disease. Any radiation to the head and neck region. Also, after the scope, there's adenohypertrophy, there's history of trauma to the face or nose less than 3 months, any craniofacial abnormalities, pregnant ladies, or immunocompromised patient like tuberculosis or diabetes mellitus. For sample size, from sample calculator, unit of biostatic and research methodology USM, therefore our sample size was 63. This is the flowchart for our study. Started with the double translation, both forward and backward translation. Then after came out with the draft Bahasa Melayu scale, we proceed with content validity to the experts and face validity to the patient. Both validity phases, we calculated the validity index. After came out with the final Malay versions, we started with the actual study at the clinic and data collection were done. Patient need to answer thrice, first during first visit or any time during visit, then after 2 weeks of first answer, the last one was 3 months after surgery. Data obtained from the questionnaire were analyzed using SPSS version 26. It was analyzed in terms of description study or analysis, intra-class correlation, test ICC or test retest, conjugate alpha, and the last one was PET test. Responsiveness, where we compared pre and post surgery. For the result and analysis, I start with the content validity index. Here we can see all the items ICVI more than 0.7 and the total SCVI average was high, which is 0.97. Followed by face validity, each item score more than 0.7 and the total average score was 0.92. For descriptive study of social demographic characteristic of all 63 participants, a total of 42 or 66.7% were male and 21 or 23.3% were female. The mean age was 33.9 with the range between 18 to 59 years old. For the reliability test in terms of internal consistency or Kronstadt alpha, the test for first answer scale was 0.83 and 0.89 for second answer, followed by 0.94 after surgery. The original nose, the overall Kronstadt alpha coefficient was 0.785, which showing the precision of the questionnaire. Other countries also show good score. For example, like French version was 0.86, whereas for Arabic, which was higher, 0.995. Reproducibility or test retest was tested with intra-class correlation ICC for each item. The test retest result for each item between first and second measurement was good with values of more than 0.7. It was higher compared to the original nose, which was 0.0702. It shows stable test. Other studies such as Dash score was 0.89, Polish version was 0.98, and Italian nose scale was 0.85. For responsiveness, comparison mean score for each item between pre and post result. The mean score a drop from 14.73 to 4.27 following surgery. It demonstrates high responsiveness and suitable for measuring treatment outcomes. PET tests also showed that the difference before and after surgical intervention was statistically significant. Others like Polish nose scale should score from 62.35 before surgery dropped to 32.35 after surgery, whereas in Greek, mean preoperative was 74.2 while mean postoperative was 12. It showed that this difference was statistically significant. As for discussion, nasal obstruction is a difficult symptom to assess objectively because it is not representing real burden for the patient. So that health-related quality of life questionnaires are frequently used in daily medical practice to understand how an individual experiences the disease. Nowadays, there is no consensus which measurement tool should be used for patients with nasal obstruction. However, nose scale and visual analog scale were used. Nose scale is a validated, reliable, and accepted tool for assessing the nasal obstruction. It was widely used in the world and can be used in any clinics, either ORL, outpatient clinic, or in private sector. It is a brief, quick, and self-administered questionnaire. It is easy to understand, and most of the patients able to complete the questionnaire less than 5 minutes. Study done by Shukla et al. They mentioned that this questionnaire was chosen because it is brief, easy to complete for the patient, and specific for nasal obstruction. And also the nose can be further applied for outcome analysis after septoplasty. We found that the instrument can assess the symptom nasal obstruction. The second one is quality of life related to this symptom, followed by treatment strategies, and you also can compare pre and post treatment, followed by clinical outcome. Dabrowski et al. Mentioned that it is the tool to get reliable score of nasal patency related to patient quality of life and influence the treatment planning and may has outcome measures. In Greek, the author mentioned that the tool could demonstrate the magnitude of change in symptoms following treatment and measure the effectiveness. It also can demonstrate success after nasal obstruction surgery. The original author and also from the German study mentioned that it can compare the effects of different treatment, for example, like between medical versus surgical therapy, and also to evaluate different therapy strategies according to the outcome. And the last one is Mozarica et al. Mentioned that the application of nurse in everyday clinical practice as well as in epidemiological efficacy and outcome research is then recommended. Our limitation is because our study did not compare with the objective measure. As a conclusion, this version is a valid and easy tool for assessing patients with nasal obstruction. Validity, internal consistency, reproducibility, and responsiveness were tested satisfactorily. We recommend using of the Malay version of the nose scale to quantify the subjective burden related to nasal obstruction and the changes following any intervention in Malaysian adult. Before I end my presentation, I would like to thank to all who had participated in the study. These are my reference, and with that, thank you.
Thank you so much to Ms. Adina Muhammad Bakri. And now let's proceed with the Q&A session. So I give the stage to the judge.
Okay, thank you, Mr. Chairperson. Okay, Assalamualaikum, Dr. Adina.
Waalaikumsalam.
Okay, can you hear me clearly?
Yes, I can hear
Okay,
you, Prof.
I think I have only two questions. The first question is focused on the flow chart of your study. Can you explain to me what is forward and backward translation? Is it from English to Malay and then from Malay to English back?
Okay. I start with the original scale, which is from the America, which is in English. And then first step is for forward from English to Malay. From that phase, I have three translator, and then discussion to create the Malay. And then from that Malay, we convert back to the back to the English version, and then we compare with the original. From that, we have the discussion and end up with the Malay version.
Okay, did you refer to an expert in ORL field for the question?
Yes, for both phases, forward and backward, there are three persons. First one from the Pusat Bahasa, the second one English teacher, and the third one is from the ORL expert rhinologist.
Okay, second question is why did your sample more than 60% is male as compared to female? Is it the nasal obstruction symptom frequently occur in male as compared to female?
Yes, from the previous prevalence study, there's more male compared to female. It's about 60 to 70%.
Okay, so
male compared to female.
So your finding is in line with previous study.
Yes.
Okay. Okay. Thank you, Dr. Adina. Dr. Yus, you can
Thank you,
proceed.
Dr. Nuzin. Assalamualaikum, Dr. Adina.
Waalaikumsalam, Doctor.
I just want to know, currently, is there any tool that you use? What is the tool that you use to settle the problem for the patient?
You mean for the Malay version or for English version?
For the Malay version.
But Malay version, as I know, only SNOT 22, but SNOT 22 is very broad because it's focusing more on rhinosinusitis. It involves nose, ear, face, and also OSA symptoms such as snoring, headache, and also daytime symptoms. For example, like somnolence or sleepiness.
So it's not specific to the nasal problem.
Yes.
So that's why you try to use this nose for, right?
Yes. This one is focusing only for the nasal obstruction symptom, Doctor.
Okay. Okay, that's all my questions.
Thank you, Doctor.
Okay, thank you to Ms. Adina Muhammad Baki and all the judges. We have come to the end of our oral session for today. Thank you to all the presenters for your participation and cooperation. And special acknowledgement goes to the panel of judge for evaluating the research presentation. And before we end the session, may I request all the participants and judge to switch on the camera for a virtual photography session. So I hope everyone can open their camera and we take our group session. Maybe we're not in a group in the physical, but we have a group touch in the future. We need to what we call adapt with the new norms. Okay, have anyone also open your camera, please? Okay, if this one, okay, so may I count? 1, 2, 3. Okay, another one. Freestyle. 1, 2, 3. Okay, so thank you. And before you leave this virtual room, I would like to remind you that all participants are required to join the second day of e-symposium, which begin at 8:30 a.m. tomorrow morning. And for your information, we have 3 plenary speech sessions, closing remarks, and a prize giving ceremony. Besides, we kindly request you to fill the feedback form via the link provided in the chat box. And thank you for all your attention, and may the best one wins. Assalamualaikum warahmatullahi wabarakatuh.